Hi, everyone. Thank you for taking time out of your day to join us for this 2024 webinar leading up to Construction Suicide Prevention Week. My name is Jeff Gamble, and I'm the steering committee chair of this initiative. What started as a regional initiative in Kansas City in 2019 has grown to nationwide effect to bring awareness to the epidemic of suicide in the construction industry with the goal of saving lives. In 2023, more than 500 organizations representing nearly 300,000 workers across 47 states and territories participated in Construction Suicide Prevention Week, and we're well on our way to exceeding those numbers this year. If you have not already, please be sure to register your company's participation on our website to receive your OSHA recognized certificate. That is at www.constructionsuicideprevention.com. With approximately 7.5 million people employed in construction in the US and far more worldwide, we still have more people who need access to tools that can save a life and reverse the trend that has placed construction as an industry of one of the highest rates of death by suicide. The Construction Suicide Prevention Week initiative provides free resources to people in and around the construction industry to help them start conversations, hold stand-down events, and share information with colleagues who may be struggling. Our goal is to put more tools in the hands of people who build our communities, and this webinar is one of the resources we're proud to be able to provide. We want today to be interactive, so please feel free to submit questions through chat or Q&A. Now let's get to today's program. Our moderator today is Beyer. Beyer, CWP, is Senior Director of Safe Workplaces for national nonprofit SAFE Project. Cal's mission in life is saving lives. Beyer has over 30 years of risk insurance management and safety, health, and well-being consulting in the construction, manufacture, and public safety industries. He helped launch the Construction Industry Alliance for Suicide Prevention in 2016, while working as a director for the risk management for a large construction employer in the Pacific Northwest. He serves on the executive committee for the National Action Alliance for Suicide Prevention and the Lived Experience Advisory Committee for the Suicide Prevention Resource Center, SPRC. He is a frequent speaker at conferences and events and a regular contributor to publications in various industries. Please welcome Cal.
Jeff, thank you very much for this opportunity to join you. You and your committee have done an outstanding job once again. And a big shout out to Angela Crawford and Isabel Wallert for the great work that Builders has done to continue emphasizing the importance of suicide prevention in our industry. One of the national initiatives that I've been trying to drive for several years is to change the terminology used from what had traditionally been called a trigger warning. With over 50% of suicides being by firearms, I felt we needed to have more sensitivity to use words like content warning to take away that triggering emotion of trigger. So this is an example of a content warning. I'm not going to go through it all, but this was something I do when I do a live presentation. Wanted to model that as an example. So as people do share lived experience with the aftermath of suicide, substance misuse, overdose, it's an opportunity to set the tone, let people know to take care of themselves and what help is generally available. The more our industry has talked about this still becomes important, but very few people today are being, quote, blindsided by the emphasis on this topic. Our industry has embraced this head on. But for everyone's purpose, 988, the new National Suicide and Crisis Lifeline, is available, and so is Crisis Text Line 741-741. There will be additional resources shared for this program. I'm really excited today to have the opportunity to co-present with a friend who I've built that friendship through this organization, Construction Suicide Prevention Week, Chris Lalevee. And then I'd like to start with Scott Kollasch. Scott is with Tria Health. He's a consulting pharmacist. Scott, why don't you give a brief self-introduction to yourself and your role on this committee?
Sure. Thanks, Cal. Like you said, my name is Scott Kollasch. I'm a clinical pharmacist with Tria Health. On this committee, I serve as kind of the clinical representative for from a healthcare standpoint to bring some educational pieces from the medication side of things to this committee.
We've got a Q&A session that we'll be moderating with you. We appreciate your insights. Thanks for participating in the Construction Suicide Week program. Thank you so much. Chris, Lalevee, give a quick overview of yourself, your background, and your role on this committee as well.
Hi, my name is Chris Lalevee. I am from International Union of Operating Engineers, Local 825. We are located in New Jersey and 5 lower counties in New York. My role in this is I run a members assistance program, and we tackle all things as far as mental health, suicide, and addiction. And as you know, I've been kicking around in this world for a little while now, and just keep popping up different places.
Chris, you've been an incredible advocate. You've been an incredible champion, not only on mental health and suicide prevention, but this topic of opioids. And this graphic really spoke to the reality of our industry. You work in heavy urban America. You want to talk briefly about this image and just how it reflects for you why we do what we're doing?
Well, the image speaks to me. It's my everyday. It's been my everyday for a long time. And seeing an image like this kind of made it very real to me, made it very real. And when you look at the statistics, that's just very real too. You're looking at buildings going up and bridges getting built and roads going in, all these things, but there are underlying issues, which we're going to talk about today. So that's why this image really speaks to me.
This topic hits across the country, cuts across every demographic. It impacts rural America at an increasing rate as well. But that image just needed to be included. I wanted folks to just know I've been waging a counterattack against opioids in the workplace and at home. We can share additional information on opioid first dose prevention strategies and tools, resources that employers can use to educate their employees. And secondly, steps and strategies that employers can take to help reduce the risk of opioids in employee injuries, workers' compensation, and on the employee benefits. Chris and I have built a program that will give you an overview that includes some of those leading gateways, but I wanted everyone to know I reached out to the American Chronic Pain Association before I began this to build sensitivity to chronic pain. I'm going to talk about that in a moment. But one of the tools I've been using to promote the importance of opioid risk reduction is an ongoing series with a publication family called Iron Markets. And they brand as For Construction Pros. There will be 17 articles that we have already outlined. 10 have been submitted, but we're featuring the leaders, the stories, the organizations that are early adopters and who are overachievers in promoting opioid risk reduction and especially emphasizing the importance of naloxone. And Chris, you were featured in an article on peer support with a gentleman named Paul Lawson, who's in Columbus, Ohio. So it's great to just see the reach and want everyone to know those links are available at that hot link or landing page. And then with respect to the American Chronic Pain Association, I grew up in a family where a member of my family experienced chronic pain from a legitimate physical injury and required large doses of opioids. And chronic pain is real. It's a very complex medical diagnosis, and the numbers are astounding. Scott and I had the opportunity to talk about this issue and how it impacts people in construction. But about 21% of adults in the US, which is 50 million people, experience chronic pain. And a large percentage have what's been described as high impact chronic pain. This results in a very significant reduction in their ability to engage in activities of daily living. That is 7%. So 17 million individuals struggling with chronic pain. So I build this sensitivity so we avoid judgment, we avoid shame, and we want people to reach in and look for help, try to identify alternatives, both pharmacological and non-pharmacological, things like mindfulness and meditation and other methods that could be used to reduce the need for opioids. And people with less shame are more likely to pursue those other alternatives. But one factor, if you have loved ones who experience chronic pain, who get large doses of opioids, if there are children in the home and they've not taken co-dispensed naloxone prescription from the pharmacist, if you can do so in a way that would encourage them and not have them be shamed or stigmatized, consider safe storage of medications and ask them to consider having naloxone in the home in case of an accidental overdose. Whenever I do a live presentation and I cover this topic, if there's 50 people, I will have 5 or 6 come and talk to me. If there's over 100, I'll get as many as 15 people saying, thanks for highlighting the importance of chronic pain. So Chris, we're going to have people launch Slido from your computer, from your phone. Maybe you're using a tablet today. You can scan the QR code. These will be anonymous, interactive polling questions. And Chris and I thought this would be a good way to jump right into straight talk on this particular topic. If you're not able to launch the QR code or launch Slido from the QR code, you can open a new window in your browser and type Slido, SLIDO.com, and then plug in that 7-digit number, 1641351. And generally, this works really well. And I'm going to go ahead and launch that first question, Chris, and then we'll give that a moment. But Chris, I'll start with this one. Has your organization been impacted by the opioid crisis? We gave you 4 choices, and I'm seeing responses come in, so I'm feeling really good about this. But I think what we wanted to do is give you an opportunity to respond, and then Chris and I will share some really quick observations. But we thought this would be a way to set the table. So the choices were, yes, it's been confirmed. No, but it's strongly suspected. We do not believe we've been impacted, or unsure, don't know. What I'm seeing, Chris, is results are coming in. And I'm going to move the results over to the next screen so I can see the view. We'll give this just another 5 or 6 seconds. Please feel free to participate. The more participation, the more robust and the more meaningful the results will be. Chris, what do you see?
I'm seeing no, but strongly suspected going up. The unsure and don't know. And I think that's an important one because as much time as we spend together, we don't necessarily know each other all that in-depthly when it comes to this. So, those are the things that we'll talk about and highlight.
And Chris, 3-4 years ago, when I really was ramping up my efforts around opioids, at that particular point, it was easily over 50 to 60% felt they hadn't been impacted. So much like you've described.
Yeah.
So what
I've heard it a lot, as I've told you.
Yeah.
We don't have that problem, and that's always interesting to hear.
And then we'll share some data that makes you look at that a little bit differently. So Chris, the second question we wanted to ask is, how has your organization been impacted by the opioid crisis? And we thought this would be a really good view. So you should have the opportunity to vote multiple times. We'll give you an opportunity to do so. And then Chris, you be prepared to help me analyze the results and see if they were similar to what we expected, what we typically see, or if they're different today.
Yeah.
Thanks everyone for your participation here.
Yeah. And productivity and injuries I see moving along, and that's very real. Addiction by employees or families, I don't think a lot of people realize the effect that a family member being addicted has on the person themselves as well.
Chris, with the member assistance program, you're dealing with that. Like, in a way, you're in the trenches, right? Helping individuals at the ground level.
Sometimes it's not so much about the person; it's something that's going on within their family. But I'm seeing, I'm seeing this being very, very interesting.
We felt like this would be a way for people to think about what clues might we need to look at? Sometimes it's not obvious, but if you start to see some of these examples, that difficulty of finding qualified workers, our industry does have pretty strict requirements for drug testing. We might have individuals who aren't coming, who accept a provisional offer, but then don't show up to take the drug tests, or who might fail a drug test. So we're looking at ways of maybe doing impairment testing that wouldn't test for the metabolites of a consumed substance, but maybe would look for impairment. So that's one example of why we talk about this, so we can identify new strategies that can help us meet people where they're at with respect to substance use. So Chris, anything else you want to comment on here? Pretty much across the board.
Yeah, I think it's important to highlight presenteeism. That's just it's another form of just going to work. For those that aren't familiar with that phrase, they're just going to work, and you could probably explain it better, Cal. When you say presenteeism, we understand tardiness being late and absenteeism, what that is, but presenteeism, if you could explain how we look at it.
Yeah, that idea of presenteeism is people being at work but not fully engaged. And when people lose that concentration, that's when incidents can occur, both on the personal side, injuries, third-party liabilities if they're involved with heavy equipment, or cranes, for example, Chris, like in your world, or it could be rework from a quality defect. The impact of opioids creates this ability for people to be present, but not fully engaged. And we can talk more about that when we get to Scott's questions. And then real quickly, this idea of the impact opioids has had on the construction industry. It was measured by labor rate participation. So when I saw this data back in 2018, I wish I'd seen it earlier, there was a 43% lack of male labor participation. And between 1999 and 2015, when our industry was recognizing we can't hire enough skilled and unskilled labor. So this economist from Princeton really pointed to the economic impact that opioids had. And in that time frame of 2015, there were 2 million men between the ages of 25 and 54 taking daily opioid pain medication. So that had a huge impact. And the decline was similar but less for women. So we were investing a lot in workforce development. We're still catching up, but there was a gap of individuals in our society adversely impacted by the opioid crisis. And that's why it's important for us to be sensitive. Many of these individuals didn't seek out drug use. It was doing what doctors had prescribed. And we want to build sensitivity to this problem continues to impact our businesses. So substance use, substance misuse contributes to what I call the PQRS, productivity, quality, risk, and safety. Those all impact profitability for contractors. Chris, you and I had a conversation that as owners, we see the need to invest in our people, but we also see how things like substance use impact us adversely. We need to tip the scale and have people be proactive to help on the prevention side. And moving people toward recovery is the right step. 70% of individuals with prior substance use report being in recovery. So recovery is possible. Recovery is real. And that's how we can get back those impacts. And then this is an important data as well. 70% of individuals with substance use disorder are already in the workplace. That points to this idea of recovery. That's where we need to channel more effort, teach people about prevention, treatment, and recovery. And then I just want to highlight, we put a lot of emphasis on this annual survey from Quest Diagnostics. We've had a 22-year high of positive drug tests that cuts across all industries. Construction's no longer at the high point. For many years, about 10, we were the highest industry. But we do have drugs other than medicinal and legal marijuana. This has been cocaine, amphetamines, and methamphetamine in our industry. And so we can't talk about all substances, but we do need to recognize this idea of impairment testing is coming of age. The science is there. More companies are coming out with dependable and reliable systems. It's a strategy for us in the workplace. And then the National Safety Council has highlighted some great work since 2003, but In 2018, they highlighted 70% of workplaces impacted by the opioid crisis. I bet if that survey was done today, we would see that be 90% or more.
Maybe way more, sure.
But Chris, the last item we wanted to highlight is in 2012, it was the 10th consecutive annual increase of unintentional overdoses from drugs and alcohol. So 9.5% of all occupational fatalities, this was all industries, not just construction, were attributable to overdoses. This demonstrates the need for naloxone in workplaces as part of our emergency preparedness plans. So this was a high-level overview. Chris, I'm going to turn this over to you. I'll advance the slides for you, but
Sure.
Go ahead, share a little bit about the opioid crisis as a background.
Yeah, when we look at this, this graph here, I mean, it speaks for itself when it comes to opioids in construction. We see the spike, and the dates, Cal, you already went over basically the timeline, but this shows it pretty well. And if we look at that spike, that's very real. You think about the industry, and you think about opioids, and you think about pain relief. So if we're going to say pain relief, this is the industry where it's needed. It's much needed. So, it doesn't matter what form it comes in, and how it was prescribed years ago to where it's lessened down a little bit, but it's still very much a real thing. You're saying you're 70% to 90%. I think you're spot on with that. So it's, this graph will just really show you the spike. And when you look at the dates here and how it rose, and, our industry is under attack with it.
I think it's really important, Chris, 2013 on, the emergence of synthetic opioids, fentanyl in particular, that has been such an important topic. Go ahead, share some information, Chris, that you share when you do trainings for employers and for your union members.
Yeah, when it just kind of puts it into perspective what fentanyl is. And it's 50 times more potent than heroin and 100 times more potent than morphine. That kind of a fact is very serious. And it really just kind of puts it all into perspective. When you look at this slide here, that's as much fentanyl. That's 2 milligrams of fentanyl that'll kill somebody. Now, there are people that build up tolerance, in high drug use and misuse. But when you're looking at that small of a dose is all it takes to take a life, that's real. So,
Chris, there's no quality control in the cartels.
No, it's used in prescription medicine, but that's what we have to understand. There is no quality control. When it's being mixed on the streets, there's no quality control. It's just being mixed. And this slide I can't emphasize enough to, if you have children in your house, and whether they're your own children or grandchildren or nieces and nephews visiting, when you start to look at this slide and the risk to children and young adults, you look at the statistics, and they're very real. It's a DEA breakdown that 1 in 5 adolescents have tried prescription medication. It's very easily accessible on the web, and it's been documented that youth have taken it for sleeping help, for anxiety, for loneliness, or other kinds of emotional challenges that they're going through. So, when we talk about opioids and we talk about naloxone, this is a very, very close to my heart. Unfortunately, knowing of children that have died of fentanyl poisoning, it's extremely important to have in your house.
It has been the tragedy of our era, and especially since 2013-14 with the rapid escalation, but we saw a doubling of overdose deaths during that pandemic period. And fentanyl was attributable to as high as 85 or 90% of overdoses in many states. So this is a really important conversation, and we don't have enough time today, but at the SAFE Project website, safeproject.us, we share information about college campuses, and for K-12 schools, we have a program called Safe Choices, and we teach people that just say no hasn't been effective. We need to be specific about why and what the dangers and what the risks are. And it's a really important message. Chris and I can't underscore it enough. We get calls frequently from individuals who've been adversely impacted. And Reuters News, about 6 weeks ago, had an incredible expose about the precursor drugs used to manufacture fentanyl and the pill presses that are being sent from China predominantly to Mexico to stamp these fake pills. It has contaminated this drug supply. And so having real specific conversations with your loved ones, your youth, just Chris, you said it so well, cannot be overstated. So thanks everyone for having those honest conversations with your children and loved ones. So Chris and I wanted to share some data. You might remember I've been working on suicide prevention for many years, but one of the traction points was in July of 2016 when the CDC issued the first data of suicide by industry. And it was rough data and it grew over time. Today, we know on suicide for the construction industry, per 100,000 workers, 56 die by suicide. And the number is 72 in the mining area. So last August, the CDC, in this National Vital Statistics report, looked at 22 different industries, and they combined construction and extraction because they were similar. And some of you have seen this data previously, but many people tell me they haven't seen it. So Chris and I felt we wanted to share with you. This is not for shock and awe. It's just to illustrate how real this risk is. In our industries, combined construction and extraction, that includes oil and gas, that includes some industrial trades, but specifically mining, underground, surface mining, sand, gravel, dredging. So some of those are construction operations. There are associations like the National Sand, Stone, and Gravel Association that have been addressing opioids. But combined, we were the highest occupation group. This was 162.6 overdose deaths per 100,000 workers. If you look at the chart, the next highest was food preparation and serving, so restaurants, about 117. And then you look at the next highest, and it's below 100. So kind of that average around 40. You see that little perforated line running up and down. We are 4 times higher the number of overdoses and more than 2 times the overdose deaths that we see in suicide. So what we want to do is educate Construction Suicide Prevention Week audience, all the hundreds of companies, to say, let's put the same emphasis around overdose prevention and then overdose reversal using naloxone. And then Chris, real quickly, the data was further broken down per 100,000. They segregated construction and mining. Construction individually was 131 roughly per 100,000, and mining was only 61. But what is important here, mining has a lot of heavy machinery, including haul trucks and big earth-moving equipment and conveyors.
Conveyors and things of that nature, sure.
Big, huge opportunities. In construction, the body is the machine. So we need to focus on injury prevention and injury reporting, injury management, and identify alternatives to opioids, including things like physical therapy first for rehabilitation to try to minimize that first exposure to opioids. But we wanted you to have that knowledge. And so, Chris, I'm going to turn this over to you for a moment to kick this off, and then we'll move forward.
Yeah, well, I was going to say, what do you say we pivot and we talk about the gateways to new opioid use? And there you go. You have the slide up for me and everything. So that is great. And when we look at that, I think with Safe Project, you're best to discuss the 3 gateways. And I'll pick it up after you go over that, and we'll explain how this ties in.
Well, Chris, you were one of the early adopters when I first was talking about this, and you and some of your colleagues came to a webinar I did on alternatives to pain management. I brought a company called Goldfinch Health. They optimize surgical outcomes, and I was trying to bring them into our industry to say, wow, do we need what you're doing? It's a very important issue. So collectively, I do serve as an advisor for Goldfinch, but it's an uncompensated role. I believe in their mission. I believe in supporting what they do.
Absolutely.
Together, the research they've done and I've done pointed to these three leading gateways for new persistent opioid use. And it continued to be prescriptions for on and off the job injuries. And this was important because a lot of people said, hey, didn't prescriptions decrease since 2014? Yes, by about 50%. But there was data for construction that showed for musculoskeletal injuries, we were getting prescriptions 2 times higher than the manufacturing industry. And so that was alarming to me. And not only did we get more prescriptions, we were getting larger doses for larger durations. That article, Waging a Counterattack, that I showed at the beginning, has the data that will help you make that point. But it was very alarming. So that was one. And number two, people would say, if we're seeing improvement in the workers' comp system with the jurisdictional rules and the oversight, isn't that going to be beneficial? But we do know a number of employees will decide to treat outside the workers' comp system. And frequently they're going to doctors who might not have that same level of knowledge of the dangers of people working with an opioid prescription in heavy construction, around moving machinery, in and around traffic or mobile equipment, or just doing work from heights or other elevated surfaces. So we need to be real, or realistic maybe is the right word, and to think about this, educating employees that alternatives exist. When I do all employee meetings, the number one question that employees ask, wow, should I even be taking opioids if I'm doing this work around live traffic or from elevated surfaces? And it's a great opportunity to educate workers about alternatives to opioids. And they do exist for medical, dental, and surgical procedures. This is a big issue. Over the years, I've had over 100 families tell me that their addiction or a family member's addiction came from wisdom tooth extraction, and well over 100 have done the same with a work-related injury. So educating employees, both at workers' comp and employee benefits, that alternatives do exist. Where we need to make substantial changes would be, can we work with our carriers, our partners, engage your brokers to help have these conversations? Can we get our formularies for those procedures to have alternatives available? And then use an organization like a Goldfinch Health to help you with the surgical nurse navigation. But the third area was leftover pills from the injuries and the surgical procedures. 3 billion left over every year. I want to share just a couple of quick data points. This was a study from 2019 and 2018. It was called the Plan Against Pain. These were examples of evidence. 9.5% of individuals having surgery developed in persistent opioid use. And you see some of those percentages for pretty common injuries or surgical procedures our employees would have. Knee replacement, hip replacement, hernia, and a rotator cuff were all at elevated levels.
All
this isn't to
construction
alarm
industries.
You. Yes, a
All
lot of
construction industries injuries.
These are. And then in employee benefits, the others would pertain. So these are real exposures. The last thing that we wanted to highlight, this was in the Journal of the American Medical Association. It looked at 840,000 patients. It was July of 2022. And it looked at the risk of overdose risk in a household with an opioid prescription. And what it identified is family members, not just the patient prescribed opioids, were at increased risk of overdose death. And that level was 60% increased for the first prescription. But the risk increased to 625% for the second and subsequent. What this showed was the leftover pills become a risk, and it's called diversion, where other people take the pills not intended for them because it's perceived to be safer than on the street. And the problem is a person can develop an addiction and then that pill gets cut off, then they have to turn to alternative sources. So this illustrated the importance of a prevention strategy of at-home drug deactivation and at-home disposal. Every year, the DEA and many law enforcement agencies have an annual take-back program, and a lot of pharmacies had kiosks for take-back, but we didn't always see those being used because people are busy. Those programs were on weekends. People had to sleep in. They had coaching events for their children, sports activities to take their kids to. So the pills remained in our homes. And what I found to be a really effective strategy is using these drug deactivation and at-home disposal products. This is not a commercial. This is just to say, if you want a practical solution, do a toolbox talk and share one of these products with employees. Bring samples, let them know. A company about 2 years ago, they had about 400 employees. In 10 days, they shared the pouches and they eliminated from their workers' homes almost 4,000 leftover opioid pills. So that was just an illustration of how real this risk is. So again, I just wanted to educate people, and then I wanted to share information about that Goldfinch Health. They have been a great resource. This happens to be an example of a prepared for surgery kit. But if you're interested and you say, wow, we could use that, don't hesitate to reach out to them if you're looking for additional info. And then Chris.
I think to underscore what you're saying also, Cal, with that is there are people that are in recovery and they won't turn to an opioid for pain relief, because they have that addictive gene in them. So they're not going to do that. So that, it's another way for them to get comfort in a tough situation.
The SAMHSA, the Substance Abuse Mental Health Services Administration, identifies a minimum of 23 million people in recovery. So in our industry, we know that number to be fairly high. It's not been quantified, but I think what's important, we did an article about alternative pain management in medical, dental, and surgical procedures. And so, Chris, this is another illustration, right? This pictogram of how real this is in construction.
Yeah, these 6 speak to me without a doubt, because there's so many that say, why is this such a problem in the industry? Why is construction the issue? Why? And this kind of just narrows it down. And it starts with construction as hard work. It's physical and it's hard work. That produces a high injury rate. Whether that's a serious injury or that's just, tightening and stiffening at night and all those things that happen. So your high injury rate, that calls for pain relief. And they're prescribed often. It's a very, very commonplace for something to just get prescribed, get you out of pain. And why are we doing that and going to work? Because if we don't go to work, we don't get paid. That's the trend of this industry. So I got to get to work and I got to get paid. So let me get some pain relief. Let me go to work. Let me get paid. I can't afford to take a day off. So we work while we're in pain, and we also work while we're on the medication. And you bring all that together, that'll go back a few slides about presenteeism. I think in the construction industry, you see absenteeism, but as a craft worker, you don't see as much absenteeism as you do presenteeism, because we do have to get there and we do have to make a paycheck. So when you look at these 6 factors, it just speaks to me, and it pretty much just puts it all together. And then we think about injuries and safety, whether it's working around heavy equipment or getting your hand caught in something. And we can go on forever with that. But that pictogram is spot on.
Yeah, kudos to Dr. Anne-Marie Dale, formerly at Washington University Medical School in St. Louis. I believe now she's retired. And this was a capstone project for her great career in ergonomics and construction research. We're grateful. That link is a 32-page report. It's definitely worth the read. She interviewed about 100 people. I gave her about 60 of those names. and everyone that worked with her saw her commitment to helping. And Scott, that brings us to you. Chris and I have covered a lot of these factors that impact the construction industry. And as a consulting pharmacist, we thank you for your work on the committee. Getting that medical perspective, I think, is really important. I know it's pharmacy, not medical, but it's hand in hand. So as a consulting pharmacist, how many patients do you have the opportunity to speak with each day?
Sure. I typically see between 10 and 14 patients a day, and that entails typically patients who are dealing with not only chronic pain, but also other, chronic long-term medical conditions. So here at Tria, we kind of encompass the entire patient, whether that's pain or other conditions as well.
That could be patients and or families, correct?
Correct.
Thank you. What percent of those calls on the employee benefit programs pertain to questions about opioids and non-opioid pain management?
I'd say it's probably kind of like you alluded to earlier, Cal, kind of the industry standard, around 15, 20% of patients we probably talk to are dealing with some sort of pain. Now, that's not maybe always an opioid, but it still allows us for potential intervention from a pharmacy standpoint. That could be something over the counter for pain management. It could be maybe they're pursuing something like you mentioned, physical therapy, non-medication sources. But we do see pain use quite a bit from a counseling standpoint.
Conversation we had when we prepped, talked for about an hour, just drilled you with questions. And I was like, you're going to bring such a unique perspective. I think people should be talking to their benefit providers to see if they have access to a consulting pharmacist like you have at Tria. But you work with large employers. And I just felt like, wow, when you offered to be part of this, we took you up on that. One question that Chris and I both had for you was, how often is naloxone being dispensed when opioids are prescribed?
I think the short answer is not enough. It should be prescribed a lot more frequently. The discussion should happen not only with your providers at that level, but also, after that, maybe prescription is sent to the pharmacy at the pharmacy level as well. So hopefully the goal is we need to be hitting patients more frequently and educating them on, these risks. Kind of all encompassing how you guys have already hit on the high points there, but this is something that should be addressed and people should have in their houses. It should be also probably on job sites, right? We oftentimes have AEDs on job sites, but we maybe don't carry naloxone on job sites. So that's just one easy fix that, being in this construction industry with a high rate of opioid and diversion and abuse, that's somewhere we could easily fill that gap.
Scott, what's cool about your role as a consulting pharmacist, if it hasn't been prescribed, you could be asking those questions or discover that a person has children and talk about safe medication storage, but even say, let's go back to your doctor or guide people to purchasing over-the-counter naloxone because it's now been available for the past 18 months as an over-the-counter medication.
Correct.
So you'd agree with
yes.
Conversation.
Patients with chronic pain medications, opioids, oftentimes, I hear a lot of times that, I built up a tolerance to those medicines. I maybe don't need naloxone, but kind of like we've alluded to already, right? When it's at home, it's in the hands of potentially multiple people if it's not in your medicine cabinet or put away in a safe place. So whether it's kiddos, grandkids, aunts, uncles, other family members coming to visit, there's easy access for those medications to be potentially obtained from other people.
Scott, if you don't mind, how do you talk to someone if they feel they don't need naloxone, but you'd like to open that mindset and open that opportunity? What kind of strategy do you have for that conversation?
First, it has to be non-judgmental. It's an open space. I refer to it in my field of work as like motivational interviewing. It's not just asking a bunch of open-ended or closed-ended questions. We're asking open-ended questions, getting a feel for the situation, really empathizing with patients, taking in their thoughts, practices, and histories of where their stands on that, and provide the educational piece. I'm not trying to be judgmental, but provide the patient the education for how they can utilize that.
Appreciated that you shared that perspective. Is it something you're taught in pharmacy school? Is it something you learn on the job?
A little bit of both. Pharmacy is becoming a field where they're really integration with other medical providers, so nurses, dentists, medical student studies doctors. So we're becoming more integrated from that standpoint, and not so you're in your own channel. So that very is helpful at the school level, but also in my current role, we do that sort of training actually on the job. And do regular continuing education in regards to how we should be able to talk and interact with patients.
Yeah, thank you for that. Scott, I thought one of the big takeaways when you and I had the conversation, what other drug interactions do patients and family members need to be worried about when they're taking an opioid pain management? That's something that Chris and I could never talk about. So we have opportunity to learn from you today. But what are some of those possible drug interactions that would concern you as a pharmacist?
There are many potential drug interactions with some of those opioid medications. One, it could be just even a metabolism thing. How does somebody, genetically break down medications individually, but also the risk for other drug interactions with other medications. So specifically, you might oftentimes see somebody on an opioid, but also maybe on a medication called like a benzodiazepine. So maybe something like, maybe they're using something like alprazolam or something of that nature for anxiety management. And that can definitely increase the risk for what we call respiratory suppression when you're on multiple medications like that. And oftentimes patients might be combining an opioid with a muscle relaxer and a benzodiazepine medication. And that effect can just be compounded when you're taking multiple medications. And patients maybe oftentimes don't understand that risk or that heightened risk when we're on that. And then how you tie that into, the construction industry, if we're on multiple medications that are, kind of suppressing our respiratory depression, can affect our, thought process, that kind of leads into that presenteeism and, high risk for operating, large equipment in that nature.
Scott, it's been interesting. I mentioned that I'll make this the last question too, but I mentioned when I do the all employee meetings, the biggest question that the employees have, wow, should I even be working around machinery or from heights or in traffic when I'm taking an opioid for pain management? Where is that breakdown happening? Is that a doctor not understanding the work being done? Is that not enough interaction with the employee? Is that a prescription being written? And then what role can you have having that conversation to say, does your doctor understand your work? We felt like you were going to get an exposure to construction, think about new ways you could communicate to people. But how do we move that upstream so the prescribing doctors, start to learn what some of those risks are as well? Any strategies you have? Any conversation points? Any
I think it's
methods?
Probably having the conversation. I mean, it probably starts with each healthcare provider. In healthcare, we shouldn't assume that conversation maybe was had at the doctor level. If I'm filling the prescription at the pharmacy level, have those multiple touch points with the patients at the doctor, at the pharmacy, and then if somebody has a benefit to reach out to from as part of their health plan to get to talk to a pharmacist or some sort of healthcare provider about medications as well, can be beneficial from that standpoint.
Thanks for jumping in. Thanks for sharing your knowledge and your expertise. You just struck us as a person who really cares. And we want to thank you for joining this army of helpers and to share your unique perspective. Stick around for the questions if you don't mind.
Thanks.
All right. Thanks again, Scott. I'd like to move this over to Chris. Chris, one of the things I love about you is you jump in. And you've been talking about naloxone for quite a while. Do you mind if we go to the first polling question real quickly?
Yeah,
and see
go.
what the audience says
Yeah.
about, has your organization done a toolbox talk on opioid safety and naloxone? We thought the organizers, Jeff Gamble and his committee, would like to know this information as well. So we just thought this would be really helpful.
Yeah, and like we said before, naloxone, on in the workplace, on the job sites is super important, based on what we said before. We don't necessarily know everyone so in-depthly. And I'm seeing these answers come in, and I like seeing all those yeses. You know,
We're definitely seeing this
the
grow,
no's I'd
Chris.
be interested. The no's I'd be interested to know if it is we're just not going to do that, or we don't know how to approach it. So feel free to put that in the chat. That would be interesting to know.
Yeah, thank you for that. We're going to move to the next question. And has your organization provided naloxone in workplaces and on job sites? That was a big stated goal for today. So we'd love to get responses to this question.
Yeah, and it's something that I deal with on a daily, and as you know, Cal, I've been dealing with it for quite a while. Whether somebody's going to call it an enabler or say we don't have that problem, I'm starting to see a turn in the work that I do, as I've discussed with you, that people are embracing it a little bit more. And if they're not embracing it, they're a little bit more curious about it. So things like this and what construction suicide prevention is doing here today by raising awareness is getting people maybe a little bit more comfortable talking about it and breaking down the barriers, which you can't say enough about that.
And we recognize small sample, but 50% of the respondents have already done so. That is incredible. It's great to see this momentum. We didn't see anyone say no, and we don't intend to do so. Obviously, you selected to come to this webinar, so we thought people would be more prone. But the last question we thought would be worth asking, what are the biggest barriers for stocking naloxone in the workplaces and on job sites? You should be able to vote for multiple choices. And this would just be an opportunity for people to say, what are my barriers? And Chris, then you can talk about what are some of the solutions that we've been working on, right?
Yeah, I mean, we've been working on a lot of solutions, and the barriers are there. Whether it's getting the naloxone, whether it's just lack of training, a non-understanding to it, all of those things come into play. I'm looking overall stigma about addiction. Yeah, I'll say it all the time. This is the construction industry. Concerns about liability. I love that word liability, as you know, Cal. And I'll just say, if you're worried about liability, what's the liability of doing nothing? So, we could take that and we could play with that all day, but I'm more than happy to be liable for trying to save somebody's life.
Yep. And Chris, I think what's really important here is when you look at the lack of training resources, you're going to talk about that. We can talk at Safe Project about removing that stigma. We can share with you examples of a policy. And so I think it's important, Chris, we've got a few minutes remaining, then we want to open it up for Q&A. Why don't you cover a few of those resources that do exist?
Yeah, first, on this slide, we talk about really quick how to respond to an opioid overdose. And what has just come out is pretty cool, the lay, spray, and stay. You lay the person down, you spray the product in their nostril, you stay with them, and you call 911 and get emergency help going. So if that looks as you call 911 first, or you have somebody that can call 911 for you while you're doing this. And I think it's very, very important to tell people that if it is not an opioid overdose, that spraying naloxone in someone's nose will have no effect on them. That's something that I have to lay down a lot of the time, so people will understand it. So you will do no harm to somebody. In other words, if it was a heart attack and you sprayed it in their nose, you're not going to do any harm. But
and Chris, we're going to share additional information with people about training resources. Yep. We knew we couldn't do that today, but we wanted people to have access to some information. You want to talk about being a founding member along with us at Safe Project for this Alliance for Naloxone Safety?
Yeah. The Alliance on Naloxone Safety in the Workplace was, it's just such a great project, initiative, Safe Project. Myself, I'm happy to be a part of it along with all those others throughout. And if you go to the website, you'll see the founding members of it. But it was founded by people within the construction industry for the most part. We're just all very passionate about the topic. We're an unfunded entity. Everything we did was pretty much on our own. Even the website paid for it on our own. But I invite anybody to visit the website. You're going to find sample policies for your company that you could just put into place. You're going to find training through MindForge. We'd love you to come and be a supporter. You'll see frequently asked questions. There's over 30 frequently asked questions on the site. It breaks it down. There's an email that will, you could ask further questions. And like I say, along with Safe Project, the two go hand in hand when it comes to naloxone. When I go out and I talk naloxone, I use the tools that I have. There's no sense in me reinventing the wheel. So, we talk about getting a policy in the place, and we have ANSW for that. And if you're worried about your local Good Samaritan laws, your state's Good Samaritan laws, that's all listed on Safe Project. You could get more updated information as it comes out. Safe Project is always on the pulse of it, and it's just great. So between those two websites, they're always getting updated. There's always new information. It's always getting sent out. And we look at this slide here, and it's the White House challenge. The White House took a stand. The Biden administration took a stand against the opioid epidemic. So when we talk about naloxone, I had an interesting call with somebody from the White House a few months ago, and they were with the numbers that we have in construction, they're having trouble getting data. So it's a very easy thing to do. You could go online at the link that's there provided. You could take the White House challenge, and what they're doing is they're using that for data now within our industry, within the construction industry. And with that data, what will that data do for us? That data will bring training. It'll bring more education. It'll even bring more access to the product to get it onto our sites and into our hands. So I think it's a great thing, and I'll let you talk about this guy that's a superhero here, because
Yeah,
I think
Chris,
it's awesome
real
what you guys
quickly,
are
I
doing.
want to be able to hand this off to Jeff. Wanted to share with people, if you're looking for information about a 5-minute or a 30-minute training on naloxone administration, this is the QR code you can use. These are the people we're featuring in a national campaign, Nick Williams and Heather Gutierrez, both from Colorado. I'm working to get Chris and one of his colleagues from the operating engineers as our union representative superheroes. Chris's contact information is here, mine as well. We didn't put Scott's because he works for a company and he's a consulting pharmacist for those employers. But if we have questions that we might not get to today, we as panelists will respond to every question. We'll write that through Angela and Izzy with Construction Suicide Prevention Week. And then we will be sharing some additional resources with you. So Jeff, apologize for running over just a tad. Going to hand this back over to Jeff Gamble. And thanks everyone for joining us today.
Thank you, Cal, Scott, and Chris, and thank you to everybody who joined us today. We will send a recording of today's presentation to all registered attendees, and we encourage you to share it with your colleagues. The first ever national stand down will take place next week, and we hope you will join us. Please visit www.constructionsuicideprevention.com for more information on the stand down resources and to register for your participation. Being from Kansas City, I have to add, go Chiefs. Have a great day.